Hey guys, welcome back. Today is the 7th session of our webinar set. So I hope you guys are doing okay and I hope revision's been going well. We've only got a couple of weeks now left till the exam, so hoping that everything is going okay for you. Yeah, so I know it's obviously coming up to the time now. I just want to say that, this is the time that you really need to just put in that last bit of effort, and you guys are smashing it. I remember feeling really stressed both times when I did the exam at this time, like a couple of weeks before, because there's just so much content and things. So I definitely say, like, don't worry, you've got this. Usual reminders, but anyway, like I was saying, coming up closer to the exam, I think what was most important for me, and I think really helped me, was going through, and obviously I'm saying the stuff that I use not because like I have any affiliation with them or anything, but I did use MRCPsych Mentor question bank. The first time I did the exam, I used it once and finished it. And then the second time I did the exam, I did it twice. And I think that made a big difference, just going through it twice. And I know there's not much time left, but I would really recommend just like speeding through it if you can. And then the other thing that really helped me was about the mocks, the SPMM mocks. So again, like I'm not associated with any of these kind of companies or anything like that, but I really, really found that doing the mocks was really, I wasn't getting great marks or anything. I was getting like 40%, 50%, 60% sometimes initially on the mocks, but then sort of coming up closer to the exam, it really helped. Just go through some of the last minute kind of concepts and just get that key detail for the answers. So I'd really recommend doing this. I did the mocks, all of them, twice. So yeah, if you haven't done that, I'd highly recommend doing that. I know it's a lot, but this is like the time to be really focusing, because it's what's the date today? 2nd of April, right? So 10 days left. So this is the time to really push forward, and you can do it. I know it's a bit tough, like if it's your second time or third time and you just don't feel that kind of motivation, but just really put in this effort now, the last 10 days, like leave everything else that you need to do till after the exam, and then just push for it, and then we'll hopefully get that result. Just really, really go for it now. So right, we're on the second part of clinical psychopharmacology, and so we did a bit of this last session. So we did look at the antipsychotics and antidepressants last week, and today we'll have a look a bit more detail at the mood stabilizers, and then kind of just touch on some of these other ones. Again, as always, I haven't completely covered every single thing in the syllabus, but I've included all the screenshots of the syllabus and the kind of things that we are going through, and the stuff that I think was most difficult to remember, and some of the things that that can be quite easy to forget. So I've just focused a lot on those. It's such a big topic. This is the hardest topic that I found from revision. So I would just say questions really did it for me for these ones. So I would definitely recommend doing that. Let's just revise some of the mechanisms of the mood stabilizers. So we've got Valproate to start with, which is a GABA agonist and an NMDA antagonist. Gabapentin, which is a voltage-gated calcium channel binder. Topiramate, which is a GABA agonist, NMDA antagonist, and a sodium channel stabilizer. Carbamazepine also stabilizes the sodium channels. So does phenytoin. Lamotrigine also stabilizes sodium channels and is also an NMDA antagonist. And then pregabalin is a ligand for alpha-2 delta subunit of the voltage-gated calcium channels in the CNS. So yeah, these are, again, this is sort of EMQ type of question. worth knowing these mechanisms. There's quite a lot of them. I kind of made a mind map of all of the drugs. I would definitely recommend doing that, maybe on like an A3 sheet or something like that. Just going through all of them, like putting it out on a mind map, antipsychotics, antidepressants, other drugs, and then just putting what their mechanisms are, because it helps you kind of memorize those. So let's start with lithium. So John Cade, our guy, he discovered lithium as a treatment for mania in 1949, and it's also the first-line treatment and management of bipolar disorder from NICE. It's important, obviously, because we use it a lot. It doesn't bind to plasma proteins, so basically it's kind of unbound. So that's why it kind of is so like easily effective almost. It's not metabolized as well, so it doesn't have an active metabolite, it's just pure, and it's excreted unchanged by the kidneys. As you probably know from clinical practice, blood samples should be taken 12 hours post-dose, although some of the guidance says it can be 10 to 14 hours is the acceptable range, but 12 hours is a kind of exam answer for taking lithium levels. And then there's some contraindications to lithium therapy, which are hyponatremia, being dehydrated, renal impairment, obviously, so kind of having a quite low GFR is not really recommended. Cardiac rhythm disorders, Brugada syndrome being one of those, and also Addison's disease, because that kind of affects the electrolytes as well. So I think most importantly to remember sort of the renal things and the cardiac rhythm disorders, because that's affected by lithium, and specifically Brugada syndrome. And now we're going to talk about Ebstein's anomalies. It's not actually associated with lithium, which was proven in a study, but it often comes up in like a lot of the old textbooks in the kind of lithium section. And I always like remember it with lithium, even though it's not associated with lithium. But I don't know, I feel like it is just kind of relevant because it used to be thought to be related to that. So it is actually just a congenital malformation which can be caused by other drugs, and is a prolapse of the tricuspid valve into the right ventricle. The prevalence is not that high, it's 1 in 20,000, but yes, previously was thought to be associated with lithium, but some studies have disproven that. But it still comes up kind of like as which anomaly was previously associated with this. So as you can see in the picture, it's kind of got that tricuspid valve like pushing into the right ventricle. So yeah, that's just an important note to remember. And then looking at the side effects of lithium, there's tons, which you probably have come across and seen in real life too, but just for memory, most common ones are kind of like nausea, diarrhea also, but polyuria, polydipsia, loss of appetite, even though despite having the loss of appetite, they do get weight gain, drowsiness, blurred vision. It worsens skin conditions like psoriasis, acne, eczema. All of those are worsened. You can get rashes with it, muscle weakness, dizziness, and metallic taste that can affect the taste as well. So yeah, it's pretty tough medication, but again, really effective. Although recently there's been a lot of kind of movement towards not using it so much because of the long-term effects of lithium, which we'll talk about now. But I'm sure you may have seen in practice some of the people who you know, are in their 60s or 70s, been on lithium for years, very well managed bipolar disorder, and then have to come off it because their renal function has really deteriorated. So that is a problem with it, to be honest, but it is such an effective medication. So these are the long-term effects of lithium. You've got the renal dysfunction, reduced GFR, chronic kidney disease, again, irreversible nephrogenic diabetes insipidus. So that's an important exam point, it's irreversible. Hypothyroidism, you can also get hyperthyroidism, hypercalcemia, and hyperparathyroidism. So a lot of the endocrine abnormalities can come up with lithium. So just the renal and mainly renal stuff and endocrine. And then these are the drugs to be careful, because they can increase the level of lithium in the blood, so giving you an abnormal result, and also leading possibly to lithium toxicity, which we'll talk about on the next slide. But for the exam, these are very important, like cautions to note. So NSAIDs like ibuprofen, aspirin, then the COX-2 inhibitors. So these are things like celecoxib, which are kind of used for like gastric stuff. Also for pain, they're used. And then the ACE inhibitors, obviously like ramipril, captopril, and then thiazide diuretics, such as bendraflumethiazide. So the loop diuretics, such as frusemide, are generally okay with lithium, but for the exam, definitely NSAIDs, COX-2 inhibitors, ACE inhibitors, and thiazides are kind of cautioned with using lithium, just because of their risk of causing high levels of lithium, leading to lithium toxicity. So let's talk about that. On the right, we have the AMDISEN rating scale, which is basically the lithium toxicity rating scale. And we're going from a rating of 0, which is having no clinical signs or symptoms of lithium toxicity, a rating of 1, which is mild. So this is kind of like nausea, vomiting, tremor, hyperreflexia, agitation, weakness, and ataxia. Then having a rating of 2 is a moderate lithium toxicity, which is stupor, rigidity, hypotonia, and hypotension, which is still pretty bad. But then like 3 is the worst, so that's severe. That's causing cardiovascular collapse, seizures, coma, myoclonus. So key things to note in the kind of sort of starting off of the lithium toxicity is obviously the course. Tremor, they get kind of dystonia, hyperreflexia, ataxia, nystagmus, and then also the kind of usual side effects, which can be worsened, like nausea, vomiting, diarrhea, and abdo pain. So this is the rating scale to look at lithium toxicity. Now we're going to talk a bit about monitoring. So again, this is very common to us for clinical practice, but sometimes we don't always know exactly what the rules are about what we're supposed to do in terms of guidelines and things. So generally speaking, before starting, the guidance generically has been renal function, obviously for baseline, using these, an ECG to look for any cardiac arrhythmias, TFTs for your thyroid, FBC, and BMI as well. There's also, you're advised to give have a discussion about pregnancy and contraception if it's relevant. And then in terms of the actual specific ones, so we've got the NICE guidelines, Maudsley, and BNF. So when starting lithium, NICE advised checking weekly lithium levels until stable, so until you're within the therapeutic range, which we'll talk about on the next slide. And then once you've got to that and they're stable, sort of within the correct range, and the symptoms have improved and the side effects are not excessive, then it's 3 monthly. So weekly lithium level until stable, then 3 monthly, that's NICE. And then Maudsley advises to also come up to being stable, again with kind of weekly, but then after that 6 monthly checks. So NICE is a bit more strict on it, and then Maudsley says 6 months. And then BNF advise again weekly until stable, then 3 months for the first 12 months, so every 3 months for the first year, and then after that 6 monthly. So that's the 3 different kind of rules from the different things. I think it's kind of just trying to make sure that they're just getting monitored, and not having the renal, like adverse renal function or endocrine changes, and making sure that you're not out of the range and causing toxicity. So it's kind of a generic thing, but if it's something that you want to revise in case it comes up specifically, then I think definitely worth knowing these 3 different kind of programs, I guess. And also advisable for all of them was a 6-monthly thyroid function test and renal function test at a minimum long term. So often that doesn't happen. So I think that's why they have talked about this a lot. But that's pretty much it. And then as we were speaking about the target ranges, so these are the goals for lithium therapy. And I always find it interesting that I don't know if you guys remember, like at school, we watched those, and like we did some of them, like with the Bunsen burner of burning like the metals and things and like the different colors they made. And I always remembered like lithium being, actually kind of remembered it as green, but it's not right because when I looked this up, it was red. So I remember the experiment, but I remember the color wrong. But basically the goals for the therapy. So you're aiming for a concentration of 0.4 to 1. That's the range. But then specifically for mania, you're looking at a goal of 0.8 to 1. So this is in the acute episode. This is like inpatient. So you're looking for 0.8 to 1 as your target blood level for lithium in acute episode of mania. Then the optimum was found to be sort of around 0.6 to 1.2, depending on the person. Obviously, like you don't want 1.2 if it's causing them toxicity, but some people are requiring that. The minimum is really 0.4, and the ideal target range is sort of 0.6 to 0.75. So yeah, there's a lot of numbers about here. I think I just remember 0.4 to 1 and then 0.8 to 1. And then obviously we know that lithium clearance is renal. But yeah, wherever you look in different studies and things, it's got different kind of outcomes really, but those are the main ones. And then I've also just written some risk factors for lithium toxicity. So things that can increase these lithium levels to above sort of 1 is any drugs altering the renal function, being very hot and dehydrated, like going to a sauna or like running a marathon, infections like viral infections or like traveler's diarrhea, gastroenteritis, vomiting, fevers can cause it, and again, sort of diabetes insipidus as well, nephrogenic. So mania can be triggered by a lot of medications. So this is moving away from kind of lithium now, just looking at the medications that or drugs that can just basically trigger it, and why we might need to use the lithium or think about what the cause is of a manic episode. And these can be all sorts of things. Obviously, we most commonly see it with antidepressants, but then also with steroids. So I've written both kinds, and by that I mean like corticosteroids like prednisolone, but also like anabolic steroids for bodybuilders, and that kind of like misuse as well that can trigger mania. Then all the Parkinson's drugs can, thyroxine, obviously, amphetamines, captopril, which is unusual but has been studied and seen to do that. Chloroquine, baclofen, alprazolam, I've written captopril twice, sorry, phencyclidine. So there's actually quite a few more, but these are some of the main ones. But I think mainly I'd remember antidepressants and steroids and Parkinson's drugs. I think those are probably the ones that are most relevant for us. And now we'll have a look at valproate. So valproate's really a hot topic, especially because, again, like lithium, it's found to be causing a lot of long-term issues for patients. So, it's quite relevant, really, that something like that may come up in the exam. The way it works is a GABA agonist and an NMDA antagonist. And it can be used as a mood stabilizer when patients do have renal impairment. We'll talk about in the next slide actually the side effects that are more related to valproate and why it's kind of going out of fashion a little bit. But as you can imagine, it kind of relates more to like the risks to fertility and that kind of thing. But anyway, so slightly higher doses required if sodium valproate is used. as in sodium valproate rather than valproic acid or semi-sodium valproate. So that requires a slightly higher dose. And then the three main forms are sodium valproate, which is only licensed for epilepsy technically, obviously is used, and then valproic acid, which is licensed for acute mania in the BNF, but that's not written in the Maudsley. And then semi-sodium valproate, which is Depakote, which is licensed for acute mania. So again, this is a bit of like a funny, like just British, like funny thing, I guess, that they've got some things licensed in some places and written in some places and not in other guidelines. There's no kind of, well, there is mostly, but in some things there are not, like it's not kind of like equally mapped out in all of them. But just worth knowing those three forms, and that valproic acid is licensed for acute mania in the BNF but not in the Maudsley, and then semi-sodium valproate, which is Depakote, is licensed for acute mania. So that's probably the one that is most seen in inpatient, really. But again, all of them are used, and depends on like the region and the pharmacy and other things like that. So I wouldn't like get too worried about that. And then just mentioning as well the side effects of valproate. So I found this kind of mnemonic online from Medico Maestro, and that's got some of the on the right, that's got some of the side effects of valproate. But basically we're looking again at kind of like gastro stuff like nausea, vomiting, diarrhea. We're looking at tremor, long-term kind of liver damage, gingival hyperplasia, which is kind of like the gum becomes like overgrown, sedation, weight gain, thrombocytopenia and anemia. They tend to lose hair sometimes and have curly regrowth, and then memory impairment, and very rarely can also lead to pancreatitis. So with the vomiting and diarrhea, that can be a common side effect which starts at the beginning of treatment and can subside after a few days once the body's got used to it. And the liver damage is found to be the worst in the first 6 months of valproate therapy. So again, just worthwhile noting that. And then looking at, which is quite sad, and again, one of the reasons for it going out of fashion a little bit is that, you know, the effects on women of childbearing age and the risk to the fetus. So again, studies have also shown that it can affect male fertility, which is why it's sort of getting a bit of a bad press lately. So it's also quite high risk. So congenital malformations occur in 10% of children exposed to valproate during pregnancy, which is quite high. And that's why I think it's hardly ever prescribed for that cohort. Can obviously lead to neural tube defects because of the way that it's metabolized, facial dysmorphism, cleft lip and palate. And on the left, you've kind of got example, which is some of the other features as well: craniostenosis, renal, urogenital, cardiac, and limb defects. And there's also a dose-dependent relationship between developmental delay and the dosage of valproate as well. So when the child is born, it can also be at risk of that as well if the patient or the lady was on quite a high dose of valproate. There's also a 3 times increased risk of autism when exposed in utero to valproate. Now moving on to carbamazepine. So this compound is quite similar to the tricyclic antidepressants. It's used for partial seizures first line and for neuropathic pain, but can also be used for bipolar disorder. Its mechanism is it binds to sodium channels to increase a refractory period, and it's contraindicated with monoamine oxidase inhibitors or people with bone marrow suppression. And one of the things that is often asked in exams is about the risk of one of the adverse reactions, which is a severe kind of skin reactions, which is toxic epidermal necrolysis or Stevens-Johnson syndrome, where they kind of get like a huge reaction and rash and kind of affects all of the skin, which is quite can be life-threatening. So note that for carbamazepine. These are some of the side effects of carbamazepine, apart from obviously that very like risky one, which is, you know, like an adverse drug reaction. But the normal kind of side effects that people get are, as for all of our lovely psych medications, tiredness and fatigue, vomiting and nausea, ataxia, dizziness, urticaria, so kind of skin rashes, leukopenia, thrombocytopenia, eosinophilia. You can get edema with carbamazepine and weight gain as well. Hyponatremia, increased thirst, and blurred vision, headache, and dry mouth. So those are lots of unpleasant things, but obviously it does have benefits as well. So, you know, swings and roundabouts, I guess. But these are the most important side effects to note for carbamazepine, aside from the skin reaction. So a lot of them are quite similar, aren't they? So it's quite difficult to specifically remember. But and lamotrigine. So this is an anticonvulsant drug and is used for epilepsy as well as bipolar disorder, and also can be used in depression as well sometimes. Phenytoin, again, another mood stabilizer. So this has also quite a lot of adverse effects and is not that popular. It causes sedation, ataxia, diplopia, acne, hirsutism, osteomalacia, granulocytopenia, megaloblastic anemia, and again the gum overgrowth as well. But yeah, that's just another one that we use. Phenytoin, well, actually, not really, to be honest. We don't really use it, but it's in the syllabus, so we're learning it for the exam. I think neuro like to use it a bit more than us for kind of like neurological conditions. Then Topiramate, again, that's licensed for epilepsy, but is also used for in rapid cycling or refractory bipolar disorder when lithium or valproate has not been helpful. So this is kind of almost like treatment-resistant bipolar disorder, I suppose, after lithium and valproate trials. The only thing is that it does increase the risk of kidney stones a lot, so by 10 times, and that is quite bad. Another thing to note is that carbamazepine can lower the serum concentration of topiramate, and also for valproate too. And this didn't really fit neatly into anywhere, but this is obviously a very like common exam question. So let's just revise this now. So this is the mechanism of action of the anti-dementia drugs. So first of all, we've got donepezil, which is our most famous, lovely donepezil, a reversible acetylcholinesterase inhibitor. Then we've got rivastigmine, which is reversible acetylcholinesterase and butyrylcholinesterase inhibitor. Then we've got galantamine. I like that name. But galantamine is a reversible acetylcholinesterase inhibitor and binds allosterically to nicotinic acetylcholine receptors. So yeah, just to remember that it is reversible and also binds to some nicotinic things. And then memantine is our last one, which is a bit of a rogue one, and that is a non-competitive NMDA antagonist. So those are the four. Just remember those, learn those, because they are easy marks and yeah, quite common. So we'll talk a little bit now about some of the illicit drugs and their mechanisms. So we have the drugs that target the monoamine transporters, and the key three of them are ecstasy, cocaine, and amphetamine. So we'll talk a bit about cocaine and amphetamine in a bit more detail, but basically these target the monoamine transporters, so they affect the catecholamines. Then yeah, so this is cocaine, which I actually got this image from the government website, so gov.uk. So it's a real picture of cocaine, and this blocks the dopamine transporter. So basically, you just get a lot of dopamine in there. And then amphetamine. So this is kind of like the mechanism of, again, similar to the other two that block the monoamine transporters, but essentially they bind to DAT and kind of have amphetamines have a couple of ways of making people feel good. So they they cause the dopamine to increase in the synaptic cleft, and then they also inhibit the reuptake of it. So it's got these two different things. So it binds to DAT, so it binds to the dopamine transporter, increases in monoamine transmitters by inhibiting VMAT2, which is in that picture, inhibits monoamine oxidase, and also stimulates a reversal of DAT, so kind of like sends it into the synaptic cleft. Essentially, all there is to remember is that causes a lot of dopamine to be in the synaptic cleft, like available. It's not easily taken back up, and it's kind of stopped from going in. And there's a picture there that is crystal meth. So there you have it. And then we have the drugs that work on G-coupled receptors, and that's GHB, which is kind of like known as the date rape drug. People had, in the news of like people had their drinks spiked and things like that. Then the cannabinoids and the opioids also act on G-coupled receptors. These are the drugs that act on the ion channels and the ionotropic receptors, and the key ones are alcohol, nicotine, ketamine, and the benzodiazepines also work on that. So yeah, just to remember, those are ionotropic: alcohol, nicotine, ketamine, and benzos. So now we'll just talk a little bit about some of the kind of like congenital malformations caused by some of those the medications that we discussed earlier. A lot of them are related to the mood stabilizers, but again, also sort of alcohol and the benzos as well can cause it. So we'll just go through these because it is very relevant. Carbamazepine can cause fingernail hyperplasia, so fingernails not developed properly, and craniofacial defects. So this is in the fetus and in the child when it's born, if it is born. And then phenytoin causes craniofacial defects, limb defects, mental retardation, developmental delay, basically, or low IQ. And then cerebrovascular defects as well. Diazepam, the key one is the cleft lip or palate, so cleft palate or cleft lip, or both. And then valproic acid's got loads, so it can cause, as we mentioned before, I think it was 3 times risk of autism if valproate's used in pregnancy. The endocrine disorders can be in the child as well: hypospadias, spina bifida because of the neural tube defects, cleft lip as well, and then spina bifida I've written again. And then alcohol causes fetal alcohol syndrome, which we know about, and then lithium, we did mention that. So although Epstein anomaly is not like proven in lithium anymore, it can still cause cardiac abnormalities and anomalies as well. And then looking at the, we're talking a bit about those risks, those teratogenic risks, but there are times where women who are pregnant really do need to continue taking some of these medications throughout their pregnancy, which is obviously a difficult decision and risk-benefit decision. But if they're at high risk of relapse and can't be really switched without it being high risk to them, then they are advised to continue their medications through the pregnancy. And then there are some rules for what happens if they do stay on them. So if lithium is continued, they need to have like high resolution ultrasound and echoes at certain weeks. And they also have a strict monitoring of serum levels, particularly through the 3rd trimester, and also coming up to the birth as well. It's very strictly monitored. And then carbamazepine should actually be avoided completely, but if it is absolutely necessary, then a prophylactic vitamin K should be given sort of closer to the time of birth. And then valproate again should be avoided in pregnancy. I think this is the main one where it's like really like not like really an option, to be honest. But yeah, so NICE recommends using kind of the antipsychotics that cause mood stabilizing as well. And then they recommend that if the lady who's pregnant has depression, then they would advise CBT, and if it's moderate or mild, and then an SSRI or TCA if it's a severe depression, which seems a bit kind of, I don't think that they would be on Valproate if they were just, suffering from mild depressions, but we'll, take into account what NICE recommends. So that's just the rulings of what is said. And then, so in this section, they talk about, this is the next section of the syllabus, talk about some of the non-psychotropic medications. And I haven't really gone through these because we've talked a lot about them in different sections. So we've covered a lot of things about antimuscarinics, the antiepileptics. I've got some notes on the analgesics later. And again, some of these other ones I kind of touched on. So I'm just skipping straight to ECT. So talking about the neurochemical effects of ECT, which is what they've put in the syllabus. And by the way, I refer a lot to the syllabus because obviously, like, creating the presentation, I want to be following the syllabus to make sure that all the points are covered. But to be honest, when I was doing the exam myself, a lot of my revision wasn't really syllabus focused as such, as in I just got quite I got quite bored of kind of just reading things, really. So I just mainly learned from doing questions and repeatedly, like, doing questions, getting them wrong, and just looking at them again. So if you find it, a bit daunting that I keep mentioning the syllabus and bringing that up and looking through all of the specific points, it's more just because I want to make sure that all the points are covered. And, having looked at it now, it makes a lot more sense in retrospect, seeing where the things fit in. So that's just why, to keep it kind of organized and logical, systematically for our course. But don't feel like if that's not your style of studying, I don't think that's the worst thing to not be really completely using it as a guide. But it's just helpful as well to know what they want you to know, so that you're not missing any big topics. So coming back to neurochemical effects of ECT. So ECT, obviously, we know is a very effective treatment. It can cause cell growth and synaptic connectivity increases, especially in the hippocampus, even though it does obviously cause this, memory loss after. But I think, using ECT does have improvements in synaptic connectivity. It affects the neurotrophic factors such as NF3, BDNF, and NGF, which are all associated with kind of improving, like, good levels of those are, associated with better mental health overall. The hormones are affected, so these can be kind of good and bad. Increased thyroid stimulating hormone, prolactin, cortisol, vasopressin, which is your ADH, and then ACTH, opioid endorphins, and oxytocin as well. So it causes your own hormones to raise, and that can have various effects physiologically, but as well on the mood. So that's probably one of the reasons why it's so effective. And then neurotransmitters, the decrease in 5-HT, a decrease in noradrenaline, and also the cholinergic, GABAergic, glutaminergic, and A1 and 5-HT2A. And there's activation of dopamine and serotonin in the amygdala and hippocampus. So surprisingly, it does decrease those. That's what has been written, but I'm not sure exactly how that relates to the effect of the ECT. But if anyone knows specifically how that mechanism works, then please do let me know. Or if you have any more questions about it, I'm happy to look into it in further detail. But otherwise, this is kind of what's the maximum amount you probably need to know about the neurochemical effects of ECT. And then coming back to the syllabus points again, we've got these, the therapeutics. So this is looking at, like the dose ranges, rational prescribing, monitoring, which we have covered a little bit already, some other things as well. So we'll just move on to that. So these are the minimum effective doses of antidepressants. So basically no point giving them if it's less than this, because it won't do anything. Like paracetamol, the correct dosage has to be given. And I've put them in order of kind of lowest to highest to remember it better, because I think there are some tables out there, but they kind of mix it up a bit, and I find it easier to go from in an order to help remember it. So just going through it from the start. So we've got paroxetine, fluoxetine, and citalopram, which are all at 20 a day. So that's your minimum for paroxetine, fluoxetine, and citalopram, 20 milligrams a day. Then you've got agomelatine, which is at 25 milligrams a day. You've got your mirtazapine at 30. And obviously with all of these, you can start with a lower dose, once you're like loading them up, but the minimum effective dose as an antidepressant, because obviously like things like mirtazapine and things are used at other doses for other effects, but this is for minimum effective dose as an antidepressant. So mirtazapine 30, then fluvoxamine 50, sertraline 50, duloxetine 60, venlafaxine 75, trazodone 150, and meclobamide 300. So as I was saying, like things like venlafaxine, you often see it, started at 37.5, but these are what the minimum effective doses are. So just take a couple of moments to remember those. And then a similar kind of thing, which is not about the minimum effective doses, but looking at the time to steady state, which we talked about in the last session, and steady state being the time when the plasma level is basically constant and the drug is effective, is how I sort of would describe steady state. Is kind of leveled out, you're not getting like a peak and a dip all the time. So with these, again, I've put them kind of like in reverse order. So the longest half-life is at the top and the shortest half-life is at the bottom. So we'll start from the longest. So aripiprazole has got a really long half-life of 75 hours. And so it takes about 2 weeks to get to steady state. And if you remember in our previous like webinar session, that basically you can improve, or not improve, but you can change the time to steady state by using things such as loading doses. So that can be changed, but aripiprazole is the longest. Then after that, you've got olanzapine. It's got a half-life of 30 hours and it takes about a week to get to steady state. Then you've got risperidone, which has got a half-life of 20 hours, and it takes about 2 to 3 days taking it orally to get to steady state. Then clozapine's got a half-life of 12 hours, takes about 2 to 3 days as well. Amisulpride is also 12 hours, again 2 to 3 days to steady state. And then ziprasidone is 7 hours, so it's a bit shorter, again 2 to 3 days. And then quetiapine is 6 hours. So obviously this is like not worked out by me exactly, the time to steady state. I do find it interesting that it's given 2 to 3 days as the as the time to steady state for drugs with a half-life of 20 hours and with 6 hours. But if you recall that it takes about 4.5 half-lives to get to steady state, you can kind of work out what the rough amount of time would be. So that would not make sense with the risperidone, but maybe with the others approximately. So the main ones I'd say to note is probably the aripiprazole has got the longest, and olanzapine second, then maybe quetiapine, and then just remember the other ones are sort of in between. And then we're looking at the half-lives of the benzodiazepines. So again, I've done it in order. So chlordiazepoxide has got your half-life of 5 to 30 hours. So that's like quite short. And then again, oxazepam, again, quite short, 6 to 10 hours. Alprazolam, 10 to 15 hours. Nitrazepam, 15 to 38 hours. Temazepam has got 8 to 22 hours. lorazepam 10 to 20 hours, clonazepam 18 to 50 hours, and then diazepam 20 to 100 hours. Yeah, this is can be quite sort of tricky to learn in terms of just, it's one of those memorization type of things, but I always remember diazepam being up to 100 hours because it stays for ages, especially in urine drug screens and things for people. And then the other shorter half-life benzodiazepines obviously can come out of the system a lot quicker and like are used for things like procedures, like for example endoscopy and that kind of thing. So they've got a lot shorter half-lives. And then the other ones to note are zolpidem, it's got a half-life of 2 hours, zaleplon's got a half-life of 2 hours, and zopiclone's got around 5 to 6 hours. So those are your half-lives for benzodiazepines. So I think we'll just take a 10-minute break there, and we'll come back in 10 minutes, and we'll be moving on to the prescribing in special circumstances after the break. So I'll see you guys back here in 10 minutes. Okay, hey guys. Hope you had a good break. Let's move on to some prescribing in special circumstances. So we'll start with prescribing in hepatic failure. So we're looking here at the sedatives. So I remember this by LOTS, which is like the mnemonic that I use to remember the sedative prescribing in hepatic failure. So lots of sedatives you can think of for people with liver disease. And these are obviously lorazepam, oxazepam, temazepam, and you can use a low dose of zopiclone. 3.75 is recommended. Obviously, that's kind of fairly low dose. And then in terms of what actually happens and why we need to reduce the doses and things, and some types, we've got the reduced ability to metabolize, so increased risk of toxicity, and enhanced dose-related side effects if it's not cleared properly. And then we've got reduced ability to synthesize the plasma proteins, so you can have toxicity from drugs that are mainly bound to plasma proteins. And then also the reduced hepatic blood flow in hepatic failure can cause elevated levels of drugs that are involved in first pass metabolism as well. And then looking at the antipsychotics, so the mnemonic is SAP. I don't know how useful that is to remember. I don't think I actually remembered that, but maybe you can. So the antipsychotics that you can use in hepatic failure, so in liver failure, are sulpiride, amisulpiride, and you can use paliperidone depot. So that's the antipsychotics that you can use in hepatic failure. And then in terms of the antidepressants, so the ones that you can use are paroxetine, vortioxetine, citalopram, and sertraline, or at least these are the kind of more recommended ones. Whereas you must not use any MAOIs, so any MAOIs, monoamine oxidase inhibitors, or tricyclic antidepressants should not be used in hepatic failure. And then the mood stabilizer that you can use or should use in hepatic failure is lithium. That is acceptable to be used in hepatic failure. Now let's move on to renal failure. So looking at the antipsychotics. So while in hepatic failure, we said that you can use sulpiride or amisulpiride. It's the opposite for renal failure. You must avoid amisulpiride. Haloperidol and olanzapine are fine to use, but yeah, you avoid the amisulpiride, and I think probably also sulpiride as well. And then with renal failure, antidepressants, again, avoid TCAs and monoamine oxidase inhibitors, but you can use the SSRIs, so sertraline, citalopram, and fluoxetine are generally quite safe to use. And then the mood stabilizers. So again, this is like the opposite way around. So in hepatic failure, you can use lithium, whereas in renal failure, lithium is contraindicated. Obviously, it's because they're doing that opposing kind of clearance, really. So hopefully you haven't got something wrong with both of them. So lithium is contraindicated, and then valproate and lamotrigine are fine to use for mood stabilizers in renal failure, as long as monitoring is kind of done and check the other aspects as well. And then also, lastly, lorazepam and zopiclone are fine in renal failure. So the normal doses are okay. Now let's look at the prescribing in the elderly, which was a point on the syllabus. So one of the most common reversible causes of delirium and like dementia type symptoms in the elderly is medication related, so polypharmacy or drug related. And particularly for the elderly, the worst ones are the anticholinergics, benzodiazepines, and the opioids. As you can imagine, and probably seen again in kind of doing medical jobs, that these are really really have quite bad effects on the elderly. And then the worst one in terms of sort of other drugs or like antipsychotics is haloperidol, but the other neuroleptics are also quite bad for them. Opioids double the risk of delirium in medical surgical patients as well. And delirium is actually a bit less common in the newer antipsychotics, but is still a risk that does occur in the elderly. And the reason why these changes happen and why we have to look at the prescribing a bit more closely is because of the physiological changes that occur in the elderly and in their kind of physiological state. And we'll just go through these so that we can understand why it's relevant. So in the elderly, there's a reduced gastric acid secretion and reduced gastric motility as well. So both of those things together reduces the absorption of a drug. In the elderly, they're kind of, I don't know, imagine them like a bit dry. They're not as well hydrated. They kind of have less like venous capacity almost. So they have less body water overall, and they have more body fat in relation to other things like kind of the proportions that you have when you're younger. So there's less body water and there's more body fat, and there's also less albumin as well. So what that means is with water-soluble drugs, so drugs that are kind of, I was going to say eaten, I guess, swallowed and then taken into the stomach and absorbed, so into the bloodstream, because there's less water in the body, essentially, there's kind of like an increased blood level of the water-soluble drugs. So it's kind of just like increasing that concentration. And then there's a decreased blood level of the lipid-soluble drugs because they've got more body fat. There's basically more body fat, so that drug gets spread out more. So there's an increased volume of distribution. So there is a decreased kind of blood level of the lipid-soluble drugs. And then there's an increased amount of active drug as well, which is we'll talk about that in the next slide, but that's also one of the reasons why we prescribe lower doses in the elderly, is because they have less plasma proteins like such as albumin. So those proteins don't take up the drug. So the drugs are only really kind of effective in their free or unbound form. So when less of them are being bound to proteins, there's an increased amount of that active drug. So that means that it's taken up more. So they can be more kind of like risky in terms of side effects or anything really. So that's why we prescribe a bit less. And we'll talk about that now, looking at those physiological kind of changes and how they affect our prescribing. So first of all, the hepatic metabolism decreases with age. So the liver function just decreases overall, and that's because of like decreased blood flow as well as kind of reduced enzyme activity as well. So obviously renal function long-term decreases naturally with age, so GFR does decrease with age. And then the drugs, so because of that, the drugs excreted by kidneys, so drugs that are cleared by the kidney can accumulate, and so reduction in dose is recommended. And then also the receptor sensitivity increases. So that means that you have to have a smaller dose, and that can also increase side effect risk as well if the receptors are more sensitive. And additionally, it's been noted that the elderly require longer time to respond to treatment of any kind. But as mentioned in the previous slide, that increased amount of active drug in the bloodstream is also very important, especially with the increased receptor sensitivity, can lead to that kind of double effect of being too much medication. So that's why we have to be careful, especially with things like, I don't know, like lithium and sulfuride that are renally cleared and things that has to be used cautiously in the elderly. And then let's have a look at the physiological changes in pregnancy. So again, these are kind of the things that do come up in the exam questions and the practice questions again, but often kind of I don't know about you guys, but like I just kind of glossed over some of this some of the time because it didn't feel like it was really that important. But I think it does come up, and these are things that maybe you won't have been, interested to kind of like revise specifically, as well as the receptors and things. So hopefully it's useful going through these. So the physiological changes in pregnancy, these are most prominent in the third trimester, because obviously the fetus has grown, and the mother's body has adapted quite a lot to the changes. And obviously there's loads of changes. We can only kind of talk about a few of them, and those ones that are relevant to prescribing and to psychotropic drugs. But plasma volume does increase during pregnancy, so there's a lot more like blood, generally, and output. Albumin concentration decreases because of that increased plasma volume. So again, a similar thing to the elderly, because there's less albumin, there's kind of more unbound drug potentially. So the volume of distribution increases for lipophilic drugs as well. Due to hemodilution, there's a decrease in total plasma concentrations of albumin-bound drugs. Yes, we just mentioned that. So because of there being an increase in plasma, this decreases the total plasma concentrations of the albumin-bound drugs, because there's less albumin in that amount of plasma, which is making the drug amount less. And then high progesterone causes delayed gastric emptying and reduced small intestine motility. So what that can do is affect the absorption of the medication. So, it can lead to it being in the stomach for a long period of time, and then that can affect the absorption and the rate of absorption as well. And then estrogen and progesterone, so the hormones, can also affect the liver enzymes as well, the cytochrome enzymes, and also can affect the hepatic activity. So that can change the kind of hepatic clearance of medication and drugs. Additionally, the GFR increases by 50%, which is quite amazing, really. And that obviously causes fast elimination of some drugs, and can increase the kind of like renal clearance of things. So that can lead to medication being, eliminated more quickly, and maybe not having as much of an effect. So there is an important thing to note about dosage as well. So coming back to syllabus again, so these are some of the other things that come up in the syllabus. So we're going to have a look at that advent calendar. No, we're going to look at some adverse event reporting, and there's kind of other aspects as well. Hopefully we'll go through some of those, but starting off with the opioid receptors. So this is looking at kind of substance misuse. These are just the receptors to revise them. So we've got the mu receptor, which is important for analgesia, responsible for the feeling of euphoria, can cause constipation, respiratory depression, and is also related to dependency of opiates as well, of opioids and opiates. So kappa, that also causes analgesic effects, or all of the opioid receptors do, and it can cause dysphoria and diuresis. So it can be responsible for the kind of like confusion that occurs, for example, like in tramadol. And then delta also obviously causes analgesia, which is a very useful property of the opioids, and also can help with anxiety. So it's an anxiolytic effect of the delta receptor for opioids. So those are just three that I thought were relevant. And then moving on to the adverse drug reactions. So adverse drug reactions are basically when you have a drug prescribed at a normal dose, so the correct dose, not like too high or anything like that, but it's basically the harm that can occur with that medication when it's prescribed at its correct dose. These are adverse drug reactions. So type A is a pharmacological or expected dose-dependent type of adverse drug reaction. So like, for example, patient gets nausea when starting carbamazepine. And then as you increase the carbamazepine, they get more nauseous. And then with type A adverse drug reactions, when the drug is reduced or stopped, it should reduce as well. So there's kind of like a linear correlation between the two. And then in type B, this is an idiosyncratic or unexpected reaction. So type B adverse drug reactions, these cannot be predicted and are not necessarily related to the specific pharmacology of the drug. So these are things like, again, like for example, in carbamazepine, you can get the rare but very serious skin reactions such as TEN, the toxic epidermal necrolysis, or Stevens-Johnson syndrome, or like an allergy to the drug. So this is a type B reaction. So that's the difference between the type A and type B adverse drug reactions. And the allergic reactions, generally, just because we mentioned them, these are the kind of types. I wouldn't say like these are necessarily like pure allergic reactions, but what these are. The type 1, that's IgE mediated, and then type 2, cytotoxic. Type 3 is the immune complex, and type 4 is cell mediated. And these can have these are basically hypersensitivity reactions, and obviously can have different time periods of how they affect the person, but are kind of like relevant to this topic as well, and just covered in this section. Now we'll talk a bit about some of the licensed indications for antidepressants, and probably just whiz those through quite quickly, I suppose. These are important to note because they can come up, and yeah, they're just relevant, I suppose. They're also quite useful for general life. So nocturnal enuresis in childhood. So this is bedwetting. So in the questions, it usually asks like what would the next step be, for example. Oftentimes they're wanting you to do the psychological therapies first, obviously, like the STAR chart and other things. But then when the question's like quite severe and you feel like there needs to be like medication, you obviously use your own correct judgment for that. But when it is a medication type of question, these are the licensed medications for nocturnal enuresis. So nortriptyline, imipramine, and amitriptyline are the main ones for that. And then looking at PTSD, so again, the best, well, not the best, but maybe the best, I don't know, but the licensed medications for PTSD are paroxetine and sertraline. And for bulimia, the licensed one is fluoxetine. And then for OCD, there's quite a few that are licensed, which is quite good. So there's lots of different options clinically, but you've got clomipramine, paroxetine, sertraline, escitalopram, fluoxetine, and fluvoxamine being your licensed medications for OCD. So the next two are the same, so it's quite easy to remember together. So the phobic and obsessional states, you can use clomipramine for that. And then for cataplexy associated with narcolepsy as an adjunctive treatment, you can also use clomipramine. So this is a man who is having experiencing cataplexy. So they fall to the ground, often related to kind of emotional triggers like laughing and things. With agoraphobia and panic disorder, so these are specifically mentioned. So agoraphobia and panic disorder, these are the specific licensed medications that are available for these. So venlafaxine, paroxetine, sertraline, escitalopram, and citalopram are the ones for agoraphobia and panic disorder, and they've separated that from generalized anxiety disorder. And while like venlafaxine, paroxetine, and escitalopram are also for panic and agoraphobia, duloxetine is also licensed for GAD as well. So that's in generalized anxiety disorder. Also interestingly, so you have again venlafaxine, paroxetine, and escitalopram, which were kind of common in the last two, but also for social anxiety and phobia, you have sertraline available as licensed medication and meclobamide too. So those are the most important ones to note, licensed. So let's talk a bit now about some of the side effects and discontinuation symptoms. So all of the antidepressants have side effects, and some of these are cardiac side effects. These are the most important things that are relevant for just kind of high yield revision. So sertraline is recommended post-MI, so kind of any post-MI questions of someone who's been discharged, develops depression, so sertraline is the recommended medication for that in terms of prescription-wise. And then in risks of serious arrhythmia, one must avoid bupropion, meclobamide, lefepramine, venlafaxine, escitalopram, and citalopram. That's because a lot of those can affect the QTC, but also just generally have cardiorhythmic sort of potential of changing the rhythm. So if the person's already at risk of arrhythmia, avoid all of those drugs. With the tricyclic antidepressants, the arrhythmic potential, so the potential to cause arrhythmia in anyone, is related to the dose, so is dose dependent. So that can be important if there is a risk and the person wants to stay on that, they can just have their dose reduced. If there's kind of high risk, obviously should just not be prescribed. Lefepramine is less cardiotoxic than the other tricyclic antidepressants. Again, just an exam note. Don't know how relevant that is in real life, but maybe it is. Generally, tricyclics obviously do cause, well, not necessarily cause, but have arrhythmogenic potential. So they affect the PR, QRS, and QT, can prolong all of those, and they also can have a risk of Brugada syndrome as well, the arrhythmia. So QT changes can also occur at normal doses of antidepressants, especially citalopram and escitalopram. They also have been well known to affect the QT. The citalopram and escitalopram is one to remember that affects the QTC even in normal doses or in the correct dose. So looking at the discontinuation symptoms of the antidepressants, so usually the discontinuation symptoms start within 5 days of stopping the medication. So within that 5 days, how bad it is or when it kind of comes up depends really on the half-life of the medication itself. But usually the experience of these symptoms, these discontinuation symptoms, is a short duration, and they often resolve on their own between sort of a day or 3 weeks from starting, from when the symptoms start. The average duration of the symptoms lasting is about 5 days. And one of the features of it being a discontinuation symptom is that the symptoms are supposed to resolve within 24 hours if the patient restarts the medication or the drug. And in order to avoid the discontinuation symptoms, as you know, we are advised to taper the drug down to stop, kind of like have a gradual decrease and avoid those discontinuation symptoms, or like do a crossover of a medication, so you're still tapering down one while bringing another one up. So discontinuation is least commonly seen with fluoxetine and most commonly seen with paroxetine and venlafaxine. You'll probably recognize that from the question banks. That's like a very common question, but also very useful. And these are some of the most common discontinuation symptoms that people experience. So I put a picture of lightning there because they can get this sensation of like electric shocks in their head or like jerking sensation. And I have seen a patient who described this kind of brain electric shock type of thing, and it did sound quite bizarre really, but I just remembered that quite vividly. So that sensations that they get. They can also kind of get like lability in mood, obviously, if they're coming off their antidepressant. That does make sense. But things like crying, insomnia, dizziness, flu-like symptoms, irritability, and also vivid dreams. And these are some of the discontinuation symptoms specifically with tricyclic antidepressants. So with amitriptyline and imipramine, you're getting the most, like that's the ones that are most commonly associated with the discontinuation symptoms, amitriptyline and imipramine. And also, again, as with all sort of common discontinuation symptoms, you're getting insomnia, but you can also get excessive dreaming and flu-like symptoms as well. So the dreaming is quite key for that one. And also same for monoamine oxidase inhibitors as well. So they can also get very vivid dreams and insomnia. So it's worth noting that all the monoamine oxidase inhibitors have strong discontinuation symptoms kind of whenever they're stopped. So it's very important to taper those. But with those ones, you can also get kind of movement disorders and ataxia as well as agitation and irritability. And I think there's one way of remembering about the kind of dreams and insomnia and stuff are the kind of, I remember that like kind of patients who say that when they start antidepressants, they often find that they can't remember any of their dreams, that they've lost all of their dreams. It's kind of just blackout at night. So if you just remember that, then you can remember that when they stop them, they tend to get that rebound effect of having a lot of vivid dreams and excessive dreaming as well. So when are people at high risk of developing these discontinuation symptoms? So people who are using antidepressants that have a very short half-life can get high risk of these symptoms. If they've been on a medication for a long time, so if they've been on it for years and they decide to stop, that can lead to discontinuation symptoms. Young people have a worse risk of them if they've ever had experience of having it before, coming off another medication or the same medication. If they've got polypharmacy, if they're taking other medications, that increases the risk. And also another thing to note is those people who get the symptom or like side effect of anxiety when they started the medication, when they started the antidepressant, are at risk of getting discontinuation symptoms. Not sure what the mechanism of that is, but I kind of, you can kind of imagine how it sort of has an effect if that person's quite sensitive, their receptors and things. Also, if the person's on a high dose of any drug, of the drug that they're stopping, then they will be at risk of developing discontinuation symptom. And also it's worth noting that agomelatine apparently does not have any discontinuation symptoms. So that's one thing to note. This is just a slide to recall the drugs that have active metabolites. This is not an exhaustive list, there's more than this, but these are some of the key ones. So codeine is metabolized to morphine, so that's its active metabolite. Imipramine becomes desipramine. Risperidone becomes 9-hydroxyrisperidone in its active metabolite form. Amitriptyline becomes nortriptyline in its active form. Fluoxetine also becomes norfloxetine, so that's pretty easy to remember. Diazepam becomes des-methyl-diazepam, and dithiopin becomes dithiopin sulfoxide. Clomipramine becomes des-methylclomipramine, and lastly, trazodone becomes MCPP. Don't ask me what that is because I don't know. That is just what it becomes, so it's probably got some very long name. That is what trazodone becomes. So just remember them as they are. We don't have to completely understand what everything is in order to get through this. Okay, so now having a look at the ADHD medications. So these are the key medications used for ADHD. So dexamphetamine, lisdexamphetamine, methylphenidate, atomoxetine, guanfacine, and clonidine. These all have their own side effects as well, and they include loads of different things like agitation, insomnia, reduced appetite, because most of them are kind of got like that stimulant aspect. Those are the side effects, as well as also kind of like gastro side effects too, so can cause stomach aches and other things. And then things like clonidine have a lot of other side effects too. And then this is the next section of the syllabus. So this is looking at basically a lot of the adverse reactions of these the medications, which we have covered as well, but they've included things like postural hypotension and sexual dysfunction. So we'll just cover a couple of those things. And I haven't included everything in terms of like NMS and things like that, because I think those are fairly straightforward to kind of learn. But we're going to talk about some of these things that are relevant on the syllabus. So I find this picture quite funny because it just looks like the person's literally just fallen flat completely. But these are the antipsychotics associated with postural hypotension, and through whatever mechanism that may be, kind of like alpha receptors or whatever, sedation, etc. These are the most important ones that are associated with postural hypotension. So ziprasidone, quetiapine, paliperidone, olanzapine, risperidone, and clozapine. And you may recall that sometimes we do when the medication is given like for the first time, sometimes they have to be monitored after. And one of the things included in that is making sure the person doesn't have like severe postural hypotension. For example, like when giving olanzapine, like a dose, the person has to be monitored for a certain amount of time after that to make sure that doesn't happen. But then if it does happen, these are the alternatives for people who've taken other medication and they've gotten postural hypotension. So you can give them trifluperazine, aripiprazole, haloperidol, sulpiride, or amisulpride, which have less of an effect on causing postural hypotension. And then moving on to the sexual dysfunction with the antipsychotics. So at the top is the medications with the least effect on sexual dysfunction, moving towards the ones with the most. So the one with the least effect on sexual dysfunction is lurasidone, and then asenapine is also got quite low effect, as well as aripiprazole. Then we're moving up to kind of like the middle, so like quetiapine, olanzapine, clozapine, and then kind of moving up towards the ones that have the most, like haloperidol, risperidone, and paliperidone, because as you probably know, risperidone and paliperidone can do that via lots of mechanisms. We'll talk about the mechanisms in a moment, but you may remember that they cause very, very high prolactin, and that can be one of the reasons why it affects sexual dysfunction so significantly. So I was just mentioning how do the antipsychotics cause this sexual dysfunction, because this kind of mechanism is a bit complex to understand. So a lot of the antipsychotics, as we know, decrease dopamine, so that directly decreases desire, and then they also can increase prolactin, which causes decreased desire, impaired orgasm, and arousal as well. So those are affected by prolactin. And then histamine antagonism, that can cause sedation, so the person is just not very awake, and that can also cause impaired arousal. Then some of the specific mechanisms are cholinergic antagonism. So this can cause erectile dysfunction due to reduced vasodilation peripherally. So cholinergic antagonism is worth noting because that can happen with many of the drugs. And then alpha receptor antagonism. This causes abnormal ejaculation as well as priapism. This is in males mostly, but also in females can cause decreased lubrication, and in males decreased erection due to the peripheral vasodilation which is caused by the alpha receptor antagonism. So these are just some of the mechanisms by which pharmacologically sexual dysfunction can occur. Obviously, it's a complex biopsychosocial thing as well. So obviously related to kind of like mood and like situational factors as well. So these are all things, and it's not always directly a cause of the medication. And then looking at some of the other side effects of antipsychotics, so there's antidopaminergic effects, which are some of the most common side effects that we see in patients who are taking antipsychotics. So tardive dyskinesias, akathisia, reduced libido, and reduced sperm count. Most of these you'll know already, but it's good just to note the more rare ones. So like menstrual disturbances, gynecomastia and galactorrhea from the prolactin increase, as well as Parkinsonism, which is quite obvious, and dystonias as well. And then these are some of the adverse side effects of antipsychotics. So the anti-adrenergic effects, which can cause ejaculatory dysfunction, as you mentioned in the sexual dysfunction slide, as well as the postural hypotension. So those things are caused by anti-adrenergic effects, which can be related to antipsychotic use. And then antipsychotics can also cause other anticholinergic and antimuscarinic effects too. So these are your general kind of antimuscarinic side effects that you can imagine, like urinary retention, blurred vision, constipation, sedation, and dry mouth. So these are well observed in all antimuscarinic or anticholinergic medications, but are specifically related to antipsychotics in this case. And then the antihistaminergic effects of antipsychotics. So these are sedation and drowsiness mainly being the most. But as you know, histamine is very important in the sleep-wake cycle. So a lot of the insomnias or sleep-related dysfunction can be related to antihistaminergic effects because of the cycle being disrupted, like excessive sleepiness in the day, leading to kind of disruption of the cycle as a whole. So just having a look at the antipsychotics and weight gain, and the mechanisms by which weight gain can occur with antipsychotic use. So we've got the 5-HT2A and 5-HT2C effects, D2 and D3 antagonism, effects on ghrelin, so kind of hunger, appetite hormone, increased serum leptin. So those two, ghrelin and leptin, like when they're in kind of balance, they can balance satiety and hunger, whereas when they're out of balance, they cause less easy kind of metabolism of weight, and basically hunger and appetite is not correctly managed according to the person's metabolism. Then H1 and M3 antagonism and hyperprolactinemia. So these are all aspects. So the reason why the increased serum leptin, it kind of goes against what you would expect, because leptin is a satiety hormone. So you would expect if the person's got increased leptin that they are feeling more satiated. Well, that would be the case, except basically the leptin receptors become desensitized. So basically once leptin is being released as satiety, it becomes less effective, and so the person needs to eat more to have that same kind of effect on the leptin receptors. All antipsychotic drugs are associated with weight gain. Obviously, some have worse effects than others. And then there's no evidence that the antipsychotics exert a direct metabolic effect. It's more related to these kind of effects on the receptors, which are affecting appetite, satiety, all of those kind of things, and also decreased levels of activity as well because of their effect on histamine and the kind of like drowsiness and sedation that they cause. So there's lots of kind of different theories about how antipsychotics cause weight gain, but these are some of the kind of theories. Again, like that leptin and ghrelin thing, and then the sedation aspect, but also like the D2 and D3 antagonism as well, because a lot of the kind of pleasure and like reward system around food and eating can be disrupted, and leading to people kind of not having that sensation of that they would normally have when eating. So that can be disrupted too. And then looking at the kind of medications that increase the risk of weight gain, so coming from lowest to highest, the lowest risk is at the top. So again, lurasidone, which seems to be quite useful because it has low sexual side effects as well. But moving up to the top, so you've got lurasidone at the bottom, the lowest risk of weight gain, ziprasidone, trifluperazine, sulpiride, haloperidol, going up to aripiprazole, which again is these are quite weight neutral, then asenapine, amisulpride, then moving up to ones that kind of affect more, so paliperidone and risperidone, quetiapine, chlorpromazine, and the ones that cause the most are clozapine, and olanzapine is the worst for increasing risk of weight gain. So useful just to note those ones, and seeing those in questions, kind of looking at the lowest being like lorazepam and then olanzapine and clozapine, excuse me, being the most high risk ones. So that's just worthwhile remembering. And then in the case of it being so negatively impacting the patient, which can be both in terms of kind of psychological things, like they really feel uncomfortable about the increase in weight for whatever reason, like the appetite and things, or if it's also metabolic. So when on antipsychotics, obviously they will have to have metabolic monitoring, but if these are causing too much distress or effect on the patient, you can switch to less weight-inducing antipsychotics. So the best ones are aripiprazole, ziprasidone, and lorazepam, which they were at the bottom of the most, like the least weight-causing. And then you can also augment using aripiprazole. This is often done as well for prolactin to reduce hyperprolactinemia. But when you've got people on olanzapine or clozapine, you can augment them with aripiprazole to help kind of like stop the severe effects of the weight gain, and that kind of aripiprazole does do something to that. Then of course you must be doing the lifestyle recommendations, so caloric restriction, low glycemic index diet, exercising, encouraging all of those things lifestyle-wise to help patients manage their own BMI and weight. But you can also recommend the GP to offer them orlistat or metformin, which are related to kind of insulin sensitivity and kind of like fat-related metabolism. So those are things that can be used to help manage weight. And then topiramate supposedly causes weight loss, so that can be used probably quite cautiously. And then liraglutide can sometimes be seen to be offered with clozapine specifically, so that is meant to reduce the effects of weight gain. So that was a bit of a whistle-stop tour through the second part of psychopharmacology, and again just covering some of the most important things that I found were high-yield questions. Same as last week, I will be taking questions that you have via the chat, and I will answer them by email later on. So just any questions, just put them into the chat and then I will get back to you guys on them. And so I hope that was useful, and anything that you are worried about, as always, please drop me a line. I'm always happy to kind of pick up on any topics that you want more clarification on, and yeah, I will get back to any questions via email, so you'll get the access to the replays as well. So hope you're all benefited from that session. Do let me know. I will be sending out kind of some feedback and stuff next week after the last session. So next week we'll be covering classification, which is our last session of the revision course, and I would be really appreciative if you could fill out some evaluation and things for me at the end of that. So we'll come to that next week. But anyway, good luck for the rest of your revision this week. Hopefully you guys have got some study leave and things as well, some time to revise. And as I mentioned at the beginning, the mocks really help me, question banks. Don't be stressed, just take it in a stride, you can do it. And yeah, I will see you guys next week at the same time for our last session, which is session 8. And I'll see you then.